Good evening, everybody. Good morning, good afternoon, wherever you are. I'm Mohamed Moti from the Sorbonne University in Paris, in France, and it is my huge and great pleasure to welcome all of you to this new initiative by the International Academy for Clinical Hematology, and this is namely the IACH Journal Club. So why a journal club first? So please allow me to spend a couple of minutes to introduce this initiative, which I think will be highly successful. I think all of us are convinced that the scientific and medical literature is growing very, very, very rapidly. And actually, most of us, we do not have time to digest all of this information. We don't have all the necessary time to have a critical evaluation and understanding of the content of a given publication. On the other hand, we all need to expand and balance our scopes. And at the end of the day, the evidence that is being published in the literature, we are evidence-based physicians and scientists and researchers, and we would like to use the evidence-based data to improve clinical practice and state-of-the-art patient care. So for this, we need interactions, we need collaboration, we need to exchange ideas. So how can this exchange practically happen? Of course, this is what usually happens in an in-person meeting of a society. But on a regular basis, actually, this is exactly the spirit of a journal club. Because a journal club is the umbrella where you have a sort of a regular gathering between physicians, scientists, researchers, any involved stakeholders, where a very focused topic with a peer-reviewed article being discussed. You present a summary, and then with the help of one or several panelists, we can initiate more discussion about this topic. We can discuss the pros and cons, the positive and negative aspects. And most importantly, at the end of the day, we would like to know whether all of this has some impact on our clinical practice. And this is really the spirit and the focus of this new initiative. And I'm sure you will love it. So for this first journal club, the steering committee of the IACH Journal Club has chosen this article just published a couple of weeks ago in the Journal of Clinical Oncology by Dr. Dimopoulos and colleagues. And this is the phase 3 randomized TOURMALINE MM4 trial. And by the way, I was pleased to see yesterday that this article has been featured in the ASCO post, the ASCO newsletter. You can see here the abstract, the summary of this article, and this is about maintenance therapy in elderly multiple myeloma patient not undergoing autologous stem cell transplantation. And the main conclusion of this randomized trial is that ixazomib maintenance in these elderly patients can extend progression-free survival with no unexpected toxicity. And the other conclusion of the authors is was that this is the first proteasome inhibitor demonstrated in a randomized clinical trial to have single agent efficacy for maintenance and is the first oral PI option in this patient population. So just for those who didn't have time to go and dig deeper into this article, and just to give the frame of the discussion that will follow, you can appreciate this is a randomized trial. You have the experimental arm, patient receiving ixazomib. You have the control arm, patient receiving placebo. It is randomization 3:2. Well, patient in the experimental arm received ixazomib 3 mg or the placebo on days 1, 8, and 15, 28-day cycle. The dose could be increased to 4 mg from cycle 5 if tolerated during the first 4 cycles. Randomization was stratified by induction, pre-induction ISS disease stage, age, and the response to initial therapy at screening, because these were patients who could achieve at least partial response to the induction after the induction regimen. And patients were able to continue treatment for approximately 24 months or until progressive disease or unacceptable toxicity, whichever occurred first. And of course, those adjustments for toxicities were permitted. And if you look into the table 1 from the trial, actually you can appreciate that the trial has focused on the maintenance phase. And for the initial induction phase, patients received several types of regimens, either bortezomib-based regimens or thalidomide, lenalidomide-based regimens or combinations. And you can see this is the summary: VMP, VCD, VTD, RT, CTD, very common regimens we all know. And in these patients, roughly 22% were able to achieve CR, 39% VGPR, and almost 38% in PR. And the median time from start of induction to first maintenance dose was 9.5 months, 9.4 in the control arm. And you can see the primary endpoint. This is the intention to treat population by an independent review, and you can appreciate there is a significant benefit in favor of the ixazomib arm. And you can see we are talking about a hazard ratio of 0.65. So roughly you have 35% improvement at a median follow-up of 21 months. So that was the summary of this paper. And here I would like to invite my distinguished panelist for tonight, Professor Mary-V. Mateos from the University of Salamanca in Spain, and Professor Kartik Ramasamy from the United Kingdom. Both of them are really top experts in this field, and I would like to discuss with them the implications of this paper on clinical practice. So Mary-V, Kartik, thank you for joining us, and I'm very grateful for your support to the IACH initiatives. And here, maybe I'll start with the ladies first. My first question is to you, Mary-V. What is your overall reaction to this paper? What are, you see the title, you see the abstract. Of course, you are a co-author, so you know the paper very well. What is your reaction here?
Well, my first reaction is the trial is definitely positive, and it meet its primary endpoint, and it's true that ixazomib as oral proteasome inhibitor, what is important, following induction in this specific population, transplant ineligible, newly diagnosed myeloma patients, resulted into a significant benefit. And the benefit is of approximately 8 months of benefit in terms of progression-free survival. But it's important also to see how the benefit is observed across all pre-specified subgroup of patients included in the analysis. And of course, I think that we have to add that ixazomib is a proteasome inhibitor of oral administration, what is definitely very convenient for the patients. Ixazomib is an excellent proteasome inhibitor from the tolerability point of view, because tolerability is excellent for the patients. So why not to consider ixazomib an excellent drug to continue after a proteasome inhibitor induction based for these elderly patients? Why not to continue with proteasome inhibition through ixazomib of oral administration as maintenance in this population? I think that this is something new, because until now, we considered always lenalidomide as standard of care to be utilized as maintenance, in spite of the fact that in the transplant ineligible population, there has not been any randomized study evaluating specifically the role of any drug in myeloma as maintenance. So I think that these are my first thoughts, my first positive thoughts about the trial, and I have also some points in which we can potentially improve, but first, the positive things.
Thank you, Mary V. So now, Kartik, what is your opinion? Again, very high level opinion. Just, you didn't dig deeper into the paper yet, and I'll have some good questions for you, for both of you, actually.
Thank you, Mohammed. And I think it's an excellent initiative, and it's always nice to discuss key papers and get everybody's views. So my top line view is, I think this is a fantastic study. So why do I say this? First of all, it's a very nicely designed phase 3 placebo-controlled clinical trial in elderly myeloma patients. Why is that important for elderly myeloma patients? Whenever you treat elderly myeloma patients, safety, tolerability is key. So you need to know what signals are true signals, and that's why doing placebo-controlled study is important. Marivi has already pointed out that we've never done proper maintenance studies in this patient population, but it was crying out for this type of study because Marivi herself led the Alcyone trial, and we now use continuous therapy for these patients with the DARA-based regimen and DARA monotherapy. And clearly that improves outcomes for patients. And we have, the French team lead the first trial, which showed that continuous lenalidomide dexamethasone improves outcomes. So we need to really challenge ourselves. Are there alternative options available to patients? And that's really how this trial, I see, is important. So one additional point I would make is we've never properly looked at proteasome inhibitor maintenance, either in the transplant eligible or ineligible setting. This is the first time we're doing it. Often people recommend Velcade maintenance in patients with the limited data, but this is the time that we are properly looking at it. That's one. And it's also, what I like about this is induction agnostic, which means many of the colleagues within IACH, may come from geographies where they would use different types of inductions to what we would typically use. And clearly this is exciting for them to see, well, it actually doesn't matter how I induce my patient, but actually once you look at maintenance, you could come in with a completely different treatment option. So I think it's a very important study, and I'm keen to deliberate on further points as we dig in deeper.
Okay, thank you very much for these positive first thoughts. And I agree with you. I think the population that has been included really and truly reflects the real-life population, in my opinion. The median age 72, 73. We know that the median age of myeloma patient is close to 70, so definitely we are on the older side. 37 to 39% of the patients were above age 75, so definitely there's no bias in favor of the young elderly patient, and all ISCS stages are represented. unfit and frail patients were included because the fit represented only 40%. Also, the high-risk cytogenetics abnormalities were well balanced, 17%, which I think reflects what we would expect in this population. Now, having said this, and you alluded to this already, Kartik, I mean, you have viewed the idea that the induction regimen was free and open, so you called it sort of agnostic to induction, as an advantage. However, one may ask whether these results are really relevant when, when I look to the regimens. I know, for instance, in the UK, you like CTD, but is CTD, and 5% receive this regimen, is CTD really a standard of care in this elderly population? You mentioned that Lendex and RD is really an approved standard of care until recently. Only 5% received this. On the other hand, we have 5% who received BTD, which we usually give induction in the young patient. And actually, most of the patients received either VMP or VCD, which I believe VCD is a sort of variation of VMP. So with this in mind, did these patients receive the best available today standard of care? And of course, we have to acknowledge that the trial started in 2015, and we are talking in 2020. So it's easier sometimes to criticize, 5 or 6 years later. So Marie-V, you want to start about the issue of induction?
Yeah, so this is an important point because it's true that the population was realistic at the time in which the trial was conducted. But it's true that today most of our elderly myeloma patients, do not usually receive only bortezomib-based combination. And in this study, for me, this is one of the points to criticize, as you said, Mohammed, but it's very easy to criticize in a retrospective way. Almost all patients were exposed previously to proteasome inhibitors. So this puts in context that it is possible to continue with the proteasome inhibition through the use of ixazomib of oral administration. But on the other side, it's true that few patients were treated with IMiD-based combination as part of the induction. But when you look to the fourth plot, you can see how the hazard ratio for patients treated with IMiD-based induction and treated with ixazomib as maintenance therapy, the hazard ratio for progression-free survival was 0.49. Putting in context how it is possible to utilize the proteasome inhibition through ixazomib as maintenance after an IMiD-based combination, or maybe after the most current standard of care we are utilizing in the transplant-ineligible population, like, for example, imagine VRD, or in some patients in which we decided to continue, or we consider the standard of care is lenalidomide, but some elderly patients do not tolerate lenalidomide. Why not to continue with ixazomib? And I think that this is, for me, an important point. It is valid for inductions based on proteasome inhibitors, but maybe for patients receiving IMiD-based combination as part of the induction, this is an excellent opportunity also to improve the maintenance therapy with the proteasome inhibition.
Kartik, what's your feeling?
Yeah, absolutely. I would agree with all of the points that Marie-V made. And Mohammed, you're also very right in pointing out, some of the induction regimens do not sit very well with our current practice. But we're always in myeloma. The problem is we get better every year in treating our patients, which is a good thing, and that's always a challenge. The other way that I'm seeing it is one of the things that comes out in the study is the fact that the deeper your remission, you tend to maintain very well with this maintenance agent. And that is important for me to mention because, as you rightly pointed out, CTD-based induction is poorly tolerated by patients and tends not to give you a deeper response in this patient population. So those are concerns I completely share. But moving forward into the future, clearly, if you're going to use a combination such as a VRD combination in the upfront setting for the elderly myeloma patients tailored to them, and then you get them into a VGPR plus response, then this study would suggest then switching to a kind of oral proteasome inhibitor in that CR-VGPR setting is going to give you an improved progression-free survival. So we have to contextualize for today, but clearly you're right in pointing out that some of the induction regimens used by patients in the study are really not relevant at this time.
So it looks to me you are both in agreement that using a proteasome inhibitor-based induction in an elderly patient does not preclude to use a maintenance with a proteasome inhibitor. But let me challenge you a little bit more. Today, in the elderly population, I think what is really approved is DARA VMP, daratumumab, bortezomib, melphalan, prednisone, including an overall survival advantage, thanks to the great work of Marie V. But we have also the approval of DARA-RFDEX, daratumumab, lenalidomide, dexamethasone, not yet an overall survival, but definitely a very nice PFS curve with longer follow-up. So do you feel that these results of maintenance with ixazomib, as shown in this study, are relevant to an induction with these regimen, assuming that we don't want to do continuous therapy, what we would like to stop? Because obviously, if you're doing continuous therapy with DARA-VMP or DARA-LenDex, then you may wonder why you have to add something. How do you feel about it, Marie? You're smiling. You're always smiling.
Well, I think that I see a clear role for DARA-VMP because well, DARA-VMP is given during 9 induction cycles, followed by daratumumab single agent, and I have to say that in Spain, we have an observational proposal in order to continue with daratumumab plus bortezomib as maintenance, given bortezomib 1 dose every 15 days for up to 2 years in order to upgrade the quality of the response and to increase, if possible, the progression-free survival. And for me, this is the ideal scenario to switch bortezomib by ixazomib. And in fact, this is something that we have discussed in the Spanish myeloma group, but unfortunately, you have to know that ixazomib is not available yet in Spain, so we can't utilize it. But for me, this is an excellent scenario, and maybe we can convert DVMP followed by daratumumab plus the proteasome inhibitor, maybe ixazomib, in a combination basically based lenalidomide free that can result maybe in progression-free survival comparable to that reported in the Maya study. Concerning the other combination you mentioned, DARA-LenDex, for me it's more difficult to introduce the ixazomib as maintenance, and I would reserve it maybe for patients that can't tolerate very well lenalidomide in the long-term follow-up. And in fact, this is something that maybe we are going to see in the Maya study, that more patients have to discontinue lenalidomide than daratumumab, that is, well, a monoclonal antibody very well tolerated. And why not in these patients, if we wanted to continue maintaining the efficacy, to switch and to introduce ixazomib as maintenance for those patients that can't tolerate lenalidomide. This is my opinion.
So, Kartik, if you are treating an elderly myeloma patient today, and I'll come back later, Marie V, to the issue of combinations and whether, you know, single agent maintenance is better than, you know, or less good than double maintenance. But today, if you're treating an elderly myeloma patient, non-transplant eligible, how do you view this kind of maintenance in your practice?
So obviously, it's exciting to see all these, results which show that clearly improved progression-free survival for patients, and clearly, as shown in the Alcyone trial, even an improved in overall survival in these patients. But I want us to kind of focus and reflect back on our routine care myeloma patients. There is, as you all know, a difference between patients who get into clinical trials to patients who we treat on a day-to-day basis. I continue to strongly believe that it is very, very challenging to give combinations of treatment for long durations for our patients. And the reason I want to entertain that thought in everybody's mind right now is that's when you look at alternatives. That's when you start to think, well, if I can't do that, what else do I do? And that's really where I see having an oral proteasome inhibition, where you're taking a tablet once a week, and where your quality of life in a placebo-controlled trial doesn't show any worsening of quality of life, does provide a suitable alternative for you to start thinking about it. I certainly find that something like a dara-lendex combination on a continuous basis in a newly diagnosed transplant ineligible patient over 75, which we have 45% in the UK, I would start to treat. I can't see that that is feasible. So we have to be looking at alternatives, and I see this trial presents us with a potential alternative for us to discuss.
Okay, so you mentioned the placebo as, and it being double-blind, and this is definitely an added value about the top high quality of this randomized trial. But then someone who is really looking in a critical fashion, to the curves, and I'm looking to the PFS curve now in front of me. If you look to the shape of the placebo curve, someone may tell you, well, this is about 9.4 months PFS. This is not what we would expect anymore today. I know it's about more the hazard ratio, but definitely someone may tell you, well, this is not really ideal as a control. Can we explain this by the heterogeneity of the different induction regimens they have received? And what are your thoughts? I mean, it's like, you have to have a critical interpretation of these curves.
Absolutely. Maybe if I can come in first, you're absolutely right. I think the control arm looks very, very weak. This is not what we would be happy with if that's our patient on that control arm with that PFS that we give an induction. We are not going to be happy about that sort of result for our patients. And certainly we have the ability to give other combinations of treatments that we've already talked about, be it Lendex continuous or VRD or even DVMP for this patient population. So you're quite right to point out that the control population, does not sit, very well. But I would just like to take us back to the point that we made earlier about this is a 2015 trial, and I think we can't, using this, hindsight view, criticize the population, at that point in time. But you're quite right in pointing out that the control population is very weak, and therefore it's easy for your test arm to beat the comparator because your comparator is so weak. If that's the point you're coming around to, Mohammed, that's quite right. I would agree with you.
Mariví?
Yeah, I also agree. It's true that, well, you are looking the progression-free survival from starting maintenance. Well, if we add the induction therapies to that, the progression-free survival overall for the control arm is approximately, 6 months longer, because we have to add. Definitely, it's not an optimal progression-free survival for the transplant ineligible population, but we have to take care because as Kartik previously remarked, that this is an induction agnostic treatment. So, and in the real life, patients are really receiving VMP, CyBorD, CTD, 4-6 induction cycles. So at the end of the day, we are sometimes always remarking the progression-free survival obtained from the clinical trials, in which we know that the population is quite selected, and maybe if we go to the real life, the median progression-free survival is not so bad. Definitely it's not optimal, and I think that the new combinations that are coming are clearly resulting in better progression-free survivals, and this is what we have to try to do for our patients, of course.
So here I have, because also we have contributions from the audience, and this is really amazing. We have a very nice question from our friend, Professor Meral Beksak in Turkey, and she's raising a very good question. How do these results in the elderly population, maintenance with ixazomib, compare to the earlier TOURMALINE study using ixazomib maintenance in a transplant eligible population? What are your thoughts?
I can start.
So I
Really,
think, yes.
yeah, go on, Marivi.
No. Go ahead, you please.
So both these trials have shown that oral ixazomib therapy has met its primary endpoint of improving progression-free survival. But clearly, we have to be very careful. They are very different populations. And both of those studies have shown a safety profile which is very consistent. That I keep going on about placebo-controlled trials and safety and tolerability. These are all very, very important for us to kind of look at. You have consistently the same safety profile. You've got the primary endpoint met. We're talking about 3 tablets a month. This is distinctly different to what the alternatives offer. So I'm quite excited about the fact that at least the results are very consistent. I'm sure we will have a further dialogue about how this compares with other maintenance and so on and so forth. We'll come on to that, but we'll have to first talk about the merits of the trials per se and what results we have seen. So both trials have met their primary endpoint, and both trials have shown giving oral ixazomib for a fixed duration period. Again, that's very important. 2 years fixed duration period, gives you this progression-free survival. I also am aware that both these trials have not reported overall survival. And certainly for transplant eligible trials, you may actually let people go because that's a different population. But for elderly myeloma patients, I'm sure you'll all want overall survival advantage. So we'll have to wait and see that. And as Marivi said, Alcyon trial already shows that there is an improved overall survival advantage. So we would want to see that is something that is coming through on longer follow-up in this patient population. So we'll have to wait and see with further data cuts.
So both of you have highlighted that we need to read the data and the results in the context when the trial was designed and was initiated. And the myeloma field is moving so quickly that sometimes we end up having results which today we feel are maybe bizarre or whatever. So here, still in 2015, as far as I know, we had already the results of lenalidomide maintenance. It wasn't approved everywhere or reimbursed, but I think 2015, that's not a long time ago. And the lenalidomide papers, published in the New England Journal of Medicine about maintenance with lenalidomide were there. So do you believe that lenalidomide should have been maybe a better control? Or actually, the question is not about comparing a PI maintenance versus an IMID, but rather maybe combining both of them if you want to improve the results. Marivi.
Yeah, so what you said is relevant concerning continuous therapy with lenalidomide and dexamethasone, because in the first study, the median progression-free survival for len-dex continuous therapy was, if I remember well, 26 months. If you evaluate what is the median progression-free survival in this study in the experimental arm from a start of induction, the median PFS is 26.3 months. And this is applicable to a proteasome inhibitor-based treatment, basically, because as we have previously discussed, a few patients had been treated with immunomodulatory drugs. So it is comparable, I would say, although we know that cross-trial comparisons are not appropriate. But why not to combine? Of course, I think that the proteasome inhibitors and the IMIDs are excellent partners to be combined, and why not to combine ixazomib with the monoclonal antibodies? And you alluded to this previously. And well, DARA VMP is basically based on DARA plus a proteasome inhibitor. And in the CASTOR study, or in the CANDOR study, or in the IKEMA study, at the end, monoclonal antibodies and proteasome inhibitors had been combined. Well, why not to combine the monoclonal antibodies anti-CD38 with the proteasome inhibitor ixazomib of oral administration once per week, monoclonal antibodies once per month, and at the end we are creating, I would say, more convenient treatments for our patients.
Kartik, you'd like to comment on this?
Yeah. I unfortunately take a slightly different view to Marivi. Marivi pointed out
the purpose of the journal club. You should not.
Marivi Marivi pointed out the PFS of the first study. I'm a big, I like the first trial, such a large trial and so much data, so many patients over the age of 75 in that trial. But one criticism I have of this particular study and the difficulty in us comparing this data PFS with first trial is this particular trial starts recruiting patients once they go into a good remission, and they're still, there's a huge patient selection going on before you get in. And personally, many people who may have participated in this trial would know that many of their patients didn't get in because they didn't have a partial response, or they had toxicity early on, or they had a poor performance status or whatever. So there's a huge selection bias. So we've taken in this particular trial a hugely well-selected patient population. I mean, that I don't have a problem with actually how the trial was conducted, but we do have a selected population here who've been taken. But that's not the case with first trial. In first trial, we recruited patients, large numbers of patients over 75, right at diagnosis, and early mortality, as we all talk about, and in the UK, you've seen a lot of our data, close to 5 to 10% of patients we lose even within the first 6 months from diagnosis. So because we have those early deaths, those PFSs drop off early in the continuous Lendex arm, which we don't see here. So I don't think it's a fair head-on-head comparison. And I think, as Mohammed said, I think the fair head-on-head comparison is to go head-on-head. And that's how you actually see the difference. I will also want to point out the Myeloma 11 study that we ran had 1,900 patients in the non-intensive arm. Just to remind our viewers and delegates today, we started with a CTDA induction and a CRDA induction, and then you got either observation or you got maintenance with lenalidomide. The PFS of CRDA induction followed by len maintenance was 38 months. And the number of patients we had over 75 was well over 35%. So that is the fairest. So I would say that, if you start with a Lendex-based induction and give, lenalidomide continuously, or a CRDA induction, A means attenuated here in the UK, then I don't think this current data sits well with me, unfortunately.
We have a very nice positive comment from our friend in Canada, Dr. Hira Mian, telling that it's very important, Kartik and Marivi, to mention the importance of the real-life patient versus, the clinical trials patient. We have a question here from Dr. Jose Malaga Zentero about, can we, do you think that based on these data, and there is a tradition in many places to use bortezomib maintenance in high-risk cytogenetics, can we use ixazomib also? And again, my role is to be fair and balanced and have sort of a very sharp reading of the paper. When we look to the table figure 2, panel B, actually, the hazard ratio for the high-risk cytogenetics overlaps on 1, I think. Yeah, so is this something you're doing? Or, I mean, in Spain it's not available, but what about in the UK, Kartik?
I mean, certainly, as we all know, I think one of the big excitement for, I'm now referring to the IXA-Lendex combination, the relapse setting, there was clear efficacy in the relapse setting, particularly for high-risk patient population. So clearly, all of us are focusing on the high-risk population within this trial. You rightly pointed out, Mohammed, that if you just purely take the high-risk population, which is your 414, your deletion 17p, your 1416 population, then unfortunately we're not seeing it. But there is another cohort that has been mentioned in this particular study, who call the expanded high-risk population, and that is how increasingly in the UK we started defining high risk, which is to include the amplification in 1q21 patients, and they're also important. They also do poorly, and it's quite interesting to see that if you were to take that view, then your hazard ratio looks a bit better. But overall, I have to say the PFS of around 10 months, which is seen in both these expanded versus high risk cohorts, is not something that sits well with us. and we would be looking to optimize that with further combinations. And the point that Marie-V made about, probably something like a DARA-ICSA combination would be a very nice thing to consider. And the reason I'm kind of pointing this out is we've learned ourselves in our high-risk population, in our largest myeloma 11 maintenance study using lenalidomide in high-risk and ultra-high-risk population. Although the delta is different between the control arm and the test arm, I'm still not very happy with the PFSs that we achieve with lenalidomide in high risk. So still an area of massive unmet need, and we really need proper trials in this setting, I would say.
So here I have for you, Marie-V, I think it's a difficult question, but we need to think about it, I think, for the future. This is from Dr. Alexis Talbot, who's from France, but he's, I think, in California these days doing some good research. The question is, based on what we know about ixazomib maintenance, lenalidomide maintenance, maybe daratumumab maintenance, if you have to design today, 2020, October 2020, a randomized trial about maintenance, what would be your experimental, what would be your control arm? I know it's very difficult, but you can speculate, Bill Gates giving you billions and you're ready to do any trial you want.
Well, this is an interesting question. Well, basically, we have pointed out at the beginning that this is the first clinical trial evaluating ixazomib, evaluating, the role of maintenance in the transplant ineligible, because the other trials evaluated the continuous therapy. So, but of course, I can imagine that I am going to be, the control arm, imagine that it would be the Alcyon study, DARA monotherapy as maintenance. Well, an optimal experimental arm would be daratumumab plus ixazomib, as I previously said. And I'm almost sure that ixazomib is going to add a benefit in improvement the quality of the responses and prolonging the progression-free survival. This is an optimal study design. Another possibility would be to go to DARA-LENDEX. This is more challenging, of course, because we know that the median PFS expected for DARA-LENDEX is, it's very long, but maybe DARA-LENDEX as continuous therapy, and this would be the standard of care, and the experimental arm would be, DARA-LENDEX, and after a specific number of cycles, imagine 1 year of 18 months, there would be two possibilities. To randomize patients to continue with len plus ixazomib or DARA plus ixazomib.
So I'm very, very grateful, Marie-V, sorry to interrupt, that you are raising the issue of the duration of treatment, fixed duration versus continuous. And we have lots of patients and their families watching us today. And obviously, we know that beside the economical factors, which are of course important everywhere today, these days, but it may have some impact, on the quality of life of the patient. And this notion of treatment-free interval, I know is very important for many, many patients, because it's always good, to receive nothing.
Yeah,
so would this be part of your thinking?
I think that this is going to be a point in which maybe Kartik is not going to agree with me, because my thought is in favor of the continuous therapy. Of course, if the tolerability is good, and this is basic from my point of view, continuous therapy and especially maintenance therapy has to meet 3 key inclusion criteria: to be effective, to be safe, and to impact as less as possible in the quality of life of the patients. So from my point of view, if these 3 criteria are met, why not to give continuous therapy for the elderly population? Because, we know that the maximum benefit is going to be obtained from the first line of therapy. And in fact, this is one of my negative points from the ixazomib trial, that ixazomib was given only for 2 years, and maybe if patients would have received ixazomib as continuous therapy or for some additional years, maybe the benefit would be higher, because in fact, if you look at the progression-free survival just after 2 years, well, you can see how the separation of the cures is, is maximum. And well, I would be in favor of continuous therapy. And maybe Kartik is not in agreement with me.
Kartik?
Okay, let me start out this way. I'm not arguing against a patient who wants continuous therapy, is feeling well on continuous therapy, and is doing well on continuous therapy. I'm arguing for the patients who cannot have continuous therapy, who have difficulty in staying on continuous therapy. And what I'm also going to add is vast number of patients are actually in that segment. And that's what I find that sometimes investigators don't recognize. Investigators don't recognize that we are not fighting against not giving continuous therapy. We want to give continuous therapy for people who are benefiting, who can take it, but we don't want to be imposing continuous therapy on patients who are struggling to take continuous therapy and not benefiting from it. I think that's where my issue is. So I think if we take that framework and start to think through it, then what we have to do is, if we want to give treatment-free interval for patients, as Mohammed said, I'm a big supporter of treatment-free interval, then the first thing is you should give meaningful treatment-free interval, not what the control arm saw in this particular study. We need to give meaningful treatment-free interval. And this is where I agree with you, Marivi, about the fact that we need to bring in potent combinations in the induction setting. And even for the period that we give, we need to give good, potent kind of maintenance regimens, which we have to evaluate in clinical trials, as you said, maybe the control arm being DARA mono versus DARA IXA, things like that. I mean, all of those are trials that we should be doing, and again, I am worried that trials that are being designed don't compare fixed and continuous, maintenance therapy as well. Cooperative groups are doing it. But whenever we have pharma studies that are being done, they're not actually comparing fixed versus, longer duration continuous therapy. It's important, and Thierry gets often asked in many conferences, RD18 versus RD continuous. There is no overall survival difference. And unfortunately, in our own Myeloma 11 study, despite the PFS differences, CRD induction followed by no maintenance has no overall survival advantage to CRD induction followed by lenalidomide maintenance. This worries me. And we have to think about, we're dealing with elderly patients here.
So just to be fair, in the TOURMALINE MM4 trial we were discussing, actually, it was about 24 months of therapy. So it wasn't like for an indefinite period. So I think we have reached the end of this first journal club of the IACH. I think you were both amazing, but also our audience, hundreds of people were connected for such a very focused topic. We can spend the whole day, the whole week, the whole month debating all of these exciting issues. And I think there is no right or wrong answer, in my opinion. It's so complex, but I believe even if we don't solve the problems, actually having a sort of a critical debate, weighing the pros and cons, it's already a good start and should give us some new ideas for the future. So you've been absolutely terrific, both of you. I'm very grateful. Thank you to all our audience, wherever you are. I hope you have enjoyed this first broadcast of the IACH Journal Club. We are fully live, guys. We are fully live, and I can tell you it's 7:49 p.m. Paris time. It's not pre-recorded. So thank you for joining, and I hope you will join us for the next Journal Club of the IACH. It looks that's going to be very, very popular. Obviously, we will not speak every week about myeloma because we will choose, the steering committee will choose a diversity of articles. So it creates a lot of work for me because I have to dig into these papers, reading them, and try, to read between the lines to ask the good or bad questions. I don't know. And please, for the audience, please do not hesitate to send your suggestions of papers. If you feel a paper is of interest, just drop me an email and I'll submit it to the steering committee and see. Obviously, the medical literature is so huge, we can't deal with everything. So again, thank you very much. And wherever you are, please stay safe and keep well. Thank you very much.
Thank you, Mohammed. Thank you, Marie.
Thank you. Thank you, Kartik.